Okay, my case is TAVR, in TAVR through stents from the iliac and abdominal aorta. Our patient presented to us about a year ago. He was 83 at that time. He had increased shortness of breath and weakness after COVID infection in December 23. He had a long history. He underwent coronary artery bypass in 1996, angioplasty of the right coronary in 2007, again of the right in 2008, and then 11 years later in 2019. At that stage, it was found that he had also severe aortic stenosis, and he underwent TAVR in 2019 with an Evolut R29. At that time, we didn't do pre-dilatation, but we needed post-dilatation with a 25 millimeter balloon. It was also noted that he had an abdominal aortic aneurysm at that stage, but it wasn't still appropriate at that time to deal with. He underwent a TOE, and that showed central aortic regurgitations through the TAVR. And he underwent also coronary angiography that showed patent lima to LAD. The rest of the left system didn't have anything significant, but the right coronary artery had a new lesion that was tackled with angioplasty at the same session of the catheterization. There was an improvement in his symptoms, and we decided to proceed with both the abdominal aneurysm that also had quite significant amount of thrombus, and at a later stage to do to put a new valve. We did the measurements of the height of the right and left coronary arteries, and we calculated the VTC of the left at 3.4 and of the right at 8.1. At the VTA was 2.5. So we decided not to protect the coronaries, and at the simulation we decided to put the valve at node 5. So the index procedure was to put a Sapien S3 at 26 at node 5. This is the aortogram pre-procedure. You can appreciate the aortic regurgitation. And we first did a balloon of the iliac stents, an aortogram afterwards, and we put a Landerquist in the left ventricle. The E-sheath through the distal stents pass easily. And then we proceeded with the valve that passed also easily through the iliacs, but at the abdominal stent, the valve was stuck. So if we kept pushing, the valve was start coming off the balloon, and you can see it here. The valve is in a slight different plane now. So instead of pushing, we pulled back, changed the orientation of the valve, and the valve passed easily through the abdominal stent. We put S-plant at the node 5, and we did a very slow deployment, as you can see, in order not to move the valve. And the final result showed that there is no aortic regurgitation, and the both coronaries were patent without problems. So in conclusion, in the past we didn't see many structural deterioration of the valves. It was uncommon, but now it will become more and more frequent due to changes in the TAVR population. The supraannular TAVR failure is more difficult to deal with, and you need to do a careful planning in every step of the procedure. Thank you for your attention.
We thank you. That's a very seldom case that's gonna, as you said, gonna happen more and more often. And can I have a comment from the panel? Some comment, some question, or from Dr. Siseloudis, if you can hear us.
Very nice case. One question. If the trick with pulling the balloon of the valve didn't work, what would you have considered? Perhaps, I don't know, left femoral, balloon from left femoral?
Yeah, maybe a balloon from left femoral, so to change the orientation. Half inflated or even with no inflation.
Okay. Before going on to Dr. Ninios, can I say that a new self-expandable valve, a new balloon expandable valve in a self-expandable valve also corrects the transvalvular and the paravalvular leak in our experience. We had a case that had a severe paravalvular and transvalvular leak that was done by a balloon expandable valve. So